All right, I have 2:45 on my clock, so let's begin today. Hi, everyone, and welcome to this session of the 2022 Culture of Data Conference. Thank you all for joining us. I am Carolyn Bryan. I use she, her pronouns, and I will be moderating this session. We also have Heather Weir, who also uses she, her pronouns, who is managing the Zoom and making sure the tech is running smoothly. You are all muted now, but if you have a question during the Q&A, please feel free to unmute. You can also use the chat box if you have questions or need anything. If you are comfortable doing so, please add your pronouns to your Zoom name by clicking the 3 dots on your video square and selecting rename. This session has been generously sponsored by Colorado Access, so we thank them for their contributions to the conference, and here is a message from them. Colorado Access is honored to be able to partner and to be a supporter of the Colorado Public Health Association Culture of Data Conference. Data is essential to making informed and thoughtful decisions and is a huge part of our deliberative process at Colorado Access. We want to sincerely thank our dedicated public health partners in Denver, Adams, Arapahoe, Douglas, and Elbert counties. We don't need much data to see that it has been a tough few years for public health workers. We are sincerely grateful to our partners and the partnerships we have forged in COVID work, hotspotting, health alliance development, and community partnerships. Viva la Public Health Partners. We have 2 presentations during this session. Each will be 20 minutes long with a 10-minute opportunity for a question and answer afterward. We will have a 5-minute block and break in between the 2 presentations. The theme of this session is equity and assessing health. Our first presentation is racism is a risk factor, not race, health inequities among Black youth in Colorado, presented by Christine Mulitauopele. Sorry, I've practiced it before, and Whitney Israel. Thank you both so much for being here. And whenever you're ready to present, please go ahead.
All right. Well, good afternoon, everyone. Thank you for coming to our session. My name is Christine Mulitauopele. I use she, her pronouns, and I'm the research program director at the Colorado School of Public Health. I work on a survey research team that administers the Healthy Kids Colorado Survey and SmartSource. I'm here today with my colleague, Whitney Israel, also she, her pronouns, our systems and operations manager. Emily Fine is unfortunately not able to join us today, but she greatly contributed to this presentation. We also want to thank and acknowledge Ming Ma, our senior analyst who ran all these analyses that we'll be getting into here in a bit. For a few more acknowledgements, I want to recognize the teams of people who work behind the scenes on the Healthy Kids Colorado Survey and SmartSource. So for CDPHE, we have Allie Maffey and Ricky Tolliver who contribute to our statewide steering committee, and Emily Fine, of course, who manages the projects. For our team at the Colorado School of Public Health, we implement the surveys used in the research that we're showing today. And I'd like to recognize Ashley, Ming, Sophie, Whitney, Hannah, Anna, and Chelsea, all for their wonderful work. We also have 2 former colleagues, Lauren Chikara and Alicia Boyer, who supported recruitment in recent years. And last but not least, would like to give a huge thank you to our participating communities throughout Colorado, specifically school and district administrators, teachers and other school staff, parents and guardians, and especially our young people, without whom none of this research would be possible. Okay, moving on. I'd like to give a brief background on the Healthy Kids Colorado Survey, or HKCS for short. I know some of you here are very familiar and it's been presented about a few times already today, so I'm going to keep it brief. The HKCS is a voluntary and anonymous student-level survey with the purpose of better understanding youth health, including physical, social, mental, and behavioral health, and the factors that help young people make healthy choices. Full administration happens in the fall of odd-numbered years, and our team at the Colorado School of Public Health is contracted by CDPHE to recruit schools administer the survey, analyze the data, and produce reports for regional and state data. We also have a steering committee with representatives from several state agencies in Colorado and a larger advisory committee, including school staff, local public health, community organizations, and youth advisors. The origins of the HKCS come from the CDC's Youth Risk Behavior Surveillance System, in which Colorado has participated in since 1991. So we just wrapped up our statewide administration of the HKCS for 2021 this past fall, and are currently processing our results for this. So unfortunately, these will not be included or discussed about today. I know everyone is anxiously awaiting them, and they're set to be released later this summer. The survey data we will be talking about today come from our 2019 statewide administration and a small supplemental administration that was done in 2020. Here, I'll talk about the key differences between the 2 years. For 2019, as a standard statewide administration, we used random sampling and had over 100,000 students participate across the state, representing about 500 middle and high schools. These statewide results are considered representative of Colorado because of the random sampling and the high levels of participation. We also used a series of race ethnicity questions aligned with the CDC and federal standards that include rather a limited number of racial ethnic categories. In the fall of 2020, following the onset of COVID-19 and the associated shutdowns and school closures, our team, with the support of CDPHE, launched a small supplemental administration of the HKCS with the purpose of measuring the impact of COVID-19 on the health and well-being of our young people. Given the extreme burden faced by schools during the fall of 2020, we knew right away that we should not and could not expect the same level of participation that we typically see in our statewide administrations, and wanted to focus on getting schools to participate who had done so previously in 2019, so we could have that pre-COVID to during COVID comparison. So we used a convenient sample, inviting only schools that surveyed from 2019. And in total, this yielded about 5,000 students, representing 73 middle and high schools who opted in and were able to successfully administer the survey. But because of this limited sample and the fact that random sampling was not used, I want to qualify that we don't consider results from 2020 to be representative of the state, only the communities that participated in the cohort. We also used 2020 as an opportunity to pilot new questions on measuring race and ethnicity that included expanded response options and aligned with recommendations out of CDPHE's Office of Health Equity. We also added a series of questions that directly measures experiences with racism and discrimination. Okay, I'm going to turn it over to Whitney for a bit to talk us through our next section.
So before we dive into the data, we always like to provide some framing around the health inequities that we're seeing. So starting with some terminology, when we talk about inequities in this presentation, we are talking about systemic, avoidable, and unjust factors that prevent people from reaching their highest level of health. When we talk about disparities, we are talking about the differences in health outcomes between people related to social factors such as race, ethnicity, gender, identity, sexual orientation, or geographic region where one lives. Measuring disparities helps us measure the progress towards achieving equity. To provide a little bit more framing, we know that generations of social, economic, and environmental inequities result in Colorado youth experiencing negative health outcomes and have a greater impact than individual choices when interpreting data. We must never lose sight of these systemic, avoidable, and unjust factors. These factors perpetuate the disparities observed in youth health measures. Further, knowing limitations exist in all of our surveillance systems, we have a responsibility to pair disparity data with more context and research about how inequities impact youth, so as to not perpetuate harmful stereotypes. From the research, we know that school and social connectedness are protective factors against many adverse health outcomes and risk behaviors. Students of color who and students who experience discrimination are less likely to feel connected and cared for at school, exposing them to additional harm for adverse outcomes related to mental health, substance use, risky sexual behavior, violence, and reduced academic achievement. There is a known test score gap seen between white compared to Black students, as well as systematic disciplinary action experienced by Black students. These two inequities are also associated with each other and with the school to prison pipeline. Better representation in teaching staff is one factor that helps close this achievement gap for students and has an impact on improved disciplinary outcomes for Black students. These relationships between school environment and student outcomes are seen in Colorado as well. Some measures from the 2019 Healthy Kids Colorado survey show related inequities in Black and Black multiracial youth. Racial inequities in mental health and suicide continue to be a pervasive health concern for adolescents in the US. Nationally, suicide is the second leading cause of death in adolescents age 15 to 19 years and has been increasing since the year 2000. However, in Colorado, it is the leading cause of death among young people ages 10 to 17. Suicidal ideation is associated with health risk behaviors and social determinants of health, such as violence exposure, mental health, sex, gender, sexual orientation, and race and ethnicity. Many disparities by race and ethnicity exist when looking at upstream predictors of suicide ideation, including the relationship between residential segregation, poverty, and suicide. There's a lack of research on the differences in Black adolescent mental health and suicide ideation outcomes. Some research points to inequities in access to mental health care and suicide misclassification, which contributes to the inconsistent findings in Black adolescent suicide rates compared to white adolescents. More research and culturally relevant prevention efforts are needed to address mental health disparities among Black youth.
Thank you, Whitney. Knowing these inequities exist, we ran some custom analyses on our statewide results from the 2019 Healthy Kids to look into health disparities experienced by Black youth, including Black multiracial youth in Colorado. We specifically looked at measures of association between race, ethnicity, and known protective and risk factors in school connectedness and mental health. For our first area, school connectedness, we observed the following disparities. Compared to white students, Black and Black multiracial students were less likely to have an adult to go to for help. And of all the protective factors asked about on the Healthy Kids Colorado survey, having a trusted adult year after year has shown to be one of the most impactful when it comes to protecting against a variety of adverse health and social outcomes. Like Whitney mentioned, having better diversity among teachers and school leaders in our schools and districts is one way to help students find someone they can identify with, someone who looks like them and comes from a similar background, someone they can trust. We also found that Black students and Black multiracial students were less likely to participate in extracurricular activities as compared to white students. Another known protective factor and a direct measure of school connectedness, as students can find belonging among peers in these various activities. It's important here to call out the privilege that is associated with participating in extracurriculars and how social inequities additionally make it more challenging for some students, for example, students experiencing poverty, to join in. For our last outcome, we found that Black students were 27% less likely to enjoy being in school than white students. This measure of school connectedness is complex and tied to whether students feel safe and welcome in their schools, have connections to their peers and teachers, and whether they find their coursework meaningful and relevant to their lives. For our next area, we assessed racial disparities, still in our 2019 data here, across mental health indicators. You can see these specific measures listed here. First, our measure of depression, which is feeling sad or hopeless almost every day for 2 weeks, considering suicide, making a suicide plan, and attempting suicide 1 or more times. Here, we're still looking at odds ratios, but now we've plotted them on a bar chart for the 4 indicators. Our gray bars represent Black students, blue bars represent Black multiracial students, Both of these groups were compared to our reference, which were white students, and that's highlighted with a green line at the 1 tick on the horizontal axis. So bars extending to the right beyond the reference line are showing an increased risk in these mental health outcomes, and lines extending to the left of the reference line show less risk or less odds. So what we're seeing here is our significant differences when the confidence interval or the whisker does not overlap with the reference line. So we see that Black multiracial students are significantly more likely to experience each of these negative mental health outcomes as compared to white students, with the most severe difference being for attempted suicide, where Black multiracial students are experiencing this negative outcome with almost twice the risk of white students. Black students are significantly less likely, on the other hand, to have felt sad or hopeless or to have made a suicide plan, but are significantly more likely to have attempted suicide as compared to white students. Like Whitney shared, we don't have great research behind these observed disparities in suicide ideation specifically, but they certainly are grounded in social determinants of health. So historical Healthy Kids data, like in 2019 and every previous year, along with a majority of surveillance data, is limited in its ability to assess the true impact of racism and discrimination, because race and ethnicity are used as a proxy. Because racism, not race, is the root cause of health inequities, it's important that we study as directly as we can the experiences of racism and its manifestations expressed in health disparities. So with our 2020 supplement, we included new measures around racism and discrimination. As a reminder, because of the limited sample size, we do not consider these results representative for our entire state, but just our participating cohort. The specific measures of racism and discrimination are listed below across the horizontal axis. So specifically whether students were treated badly or unfairly because of race or ethnicity, were watched or followed at stores or malls because of their race or ethnicity, were assumed less intelligent because of their race or ethnicity, or if students witnessed family members treated unfairly because of their race, ethnicity, language, accent, or different culture. These questions do come from a validated source, the CDC's YRBS optional question list. So we're looking at the same demographic groups with slightly different legend here. So dark blue bars are for Black students, gray bars are for Black multiracial students, and light blue bars are for white students. A significantly higher percentage of Black and Black multiracial youth experienced all 4 kinds of racism as compared to white students. Now, it's important to clarify that our intent in asking these questions was not to confirm that racism exists or who is experiencing racism, but in piloting these questions for the first time, we wanted to ensure that they were performing as expected among our population based on what we already know to be true. The real intent in adding these questions was to highlight the health inequities young Black people in Colorado face due to racism and discrimination, versus just focusing on health disparities between race, ethnicity, demographics alone. For some framing, while examining different types of racism as described earlier, and here while we're attempting to quantify the cumulative impacts of racism, we do run the risk of normalizing Black youth's experience of racism. And public health principles would urge us to remember that race is a social construct, and we are responsible for deconstructing it so that Black youth's experience of racism becomes an exception rather than the norm. So with that framing in mind, in our final analysis, experiences with racism were used as the predictor variable to 4 protective factors in school connectedness, neighborhood safety, and stress management, to help draw a more direct correlation to the root cause of these disparities that we see in health outcomes year after year in Healthy Kids data. For Black students and Black multiracial students, there was generally a dose response such that the more racism that was experienced, the greater reduction in odds these youth had in experiencing protective factors. This analysis used composite scores to measure the impact of the amount of racism experienced by young people. But to be clear, no amount of racism is acceptable for anyone to experience. These results show us that by addressing systemic and interpersonal racism, we can improve prevention efforts for youth of color experiencing health inequities. And to that end, Whitney is going to wrap up our time today with a discussion of key takeaways and action steps.
Thank you, Christine. We feel that it's important to always connect health data to key takeaways and action steps so that people can leave our presentation with some concrete example of what's next. When working towards dismantling systemic racism, we must think about solutions and action items that are also at a systems level. The following suggestions were compiled from a variety of experts and organizations working toward racial and ethnic equity and have been organized in alignment with the social ecological model. This is not a comprehensive list of what we can and should do, but rather some ideas related to the intersection of adolescent health and racism as a public health crisis. So starting at the highest level in policy, we can systematically review policies to identify and dismantle those that perpetuate inequity and racism and systematically advantage white people. We can develop more equitable policies with Black youth and community-based organizations as partners. At the community level, we can reconcile division within communities through restorative healing and accountability practices to allow for more authentic engagement in systems and policy change. We can prioritize community engagement to identify solutions to complex problems such as inequities. At an organizational level, we can increase racial and ethnic representation in staff, leadership, policy decisions, and programming and services. We can prioritize professional development that increases staff capacity to deliver culturally appropriate and youth-centered programming and services. And we can leverage school connectedness as a protective factor by promoting best practices in school safety, anti-bullying, anti-racism, inclusivity, and violence prevention. And at an individual and an interpersonal level, we can and should sustain a personal commitment to understanding and ending oppression. We should consistently reframe racism as a systemic issue, and we should always self-educate, reflect, and eliminate micro and macro aggressions that perpetuate white dominant culture. We thank you for your time today, and we want to point you to our data brief, which we summarized for you today. You can find the full brief, which includes more results and details, posted under our session schedule. Thank you so much.
Thank you, Christine and Whitney. I really appreciate it. That was a great presentation. Now we have about 10 minutes for question and answer. So feel free to jump off of mute or place a question in the chat, and I'll be sure to read it out loud. I have a question. I actually have a couple of questions, but I'll start with one and then we'll see if anyone else would like to jump in or place a question in the chat. But you mentioned, Whitney, you mentioned suicide misclassification. Can you talk a little bit about what else that may present as and what that looks like exactly?
I'm not sure I could pull out the details. That was something that I was finding when trying to find research or literature around suicide ideation among Black adolescents. And it was pointed out in several peer-reviewed articles that there is a paucity of research in this area, and the findings that we have are very inconsistent. And I think that there's only speculation on why that is and how we can improve that.
Thank you.
Sorry, I don't have a great answer.
It's okay. It's okay. And I see Dana has asked and Christine has responded, but are you continuing to use those questions related to discrimination that you piloted in 2020? And Christine answered. Go ahead.
Yep. They were certainly included in our 2021 instrument with a slight change. So in 2020, they were asked about lifetime experience with racism and discrimination. And for 2021, it was changed to past 12 months with the recognition that results are more actionable with a shorter time frame. So we are excited to see those full results here soon.
Thank you. Would anyone like to jump off mute and ask a question? I do have another one. So you both spoke a lot about connectedness. Have you seen any examples of connectedness working really well for Black youth and schools serving Black youth? And if so, kind of what were some of the things that were accomplished?
I will point out, it wasn't included in our presentation, mostly for time and just overall story, but we found that the measure of, I want to make sure I'm saying this right, students feeling that their teachers would praise them if they were doing well in school, that Black students were more likely to report that. And which is a little bit interesting given that there were reductions in some other measures of connectedness, but want to point that out as a strength and something that seems to be not a disparity, but Black youth are experiencing at higher rates. So
I think we've also gotten feedback, especially when we were writing this brief, around how we can better focus on the positive associations that Black youth have as far as being a part of a community that is supportive. And we don't have very direct or specific measures for that, but we do know that just from other research that this is a strength that we could really better measure and represent when we're talking about health outcomes.
Great, thank you. Any other questions? And then any final thoughts, Whitney or Christine, that you'd like to share with the group? No pressure, but if we do have some time, so feel free.
I think I would just add that in addition to the questions that were piloted in 2020, we made some new question changes to our demographics in 2021, specifically around our sexual orientation and gender identity questions. And I think this reflects a humility in our state's surveillance effort, where we're always trying to make improvements and align with best practice where we can, and recognize where we fell short or maybe were limited in previous years. So to that end, if there are recommendations or best practices that you all are aware of, please send them our way. I was very, very interested in today's keynote because it was focused a lot on surveillance. And we're just always learning more and looking for additional resources. So
that's a great point. And in the keynote today, they mentioned that the way that federal OMNI standards are for race and ethnicity data, I think she said they were the groundwork, right? And so, and I know that there have been some questions about the combined question for race and ethnicity, and then the two separate question, and the kind of the limited with how OMB standards are now, there's a limit, right? So how do you combat that limit, or how do you work with it within your data collection?
So we made some changes for 2021. We shifted to a combined question where Hispanic or Latinx ethnicity is treated the same as other racial ethnic categories. And I think the implications of that remain to be seen. It will take a little bit of adjusting, as some percentages, whether locally or even at the regional or state levels, might shift from historical categorizations. But from what we researched and the information we were given, this really is best practice in health equity. So I think we have a learner's attitude, and we'll see if there are changes we can make again to our 2023 instrument.
Great. Well, thank you both so much for a really informative presentation. And I appreciate everyone's time. We are going to transition and take a 5-minute break. We are coming to the close of the day. I really encourage you to take these 5 minutes to try to get some movement. I know that I've been taking my dog out and just throwing a Frisbee around with her for a quick 5 minutes, and it really helps me come back and allow me to focus. So any way that you can find some movement or grab some water, whatever it may be, before our next speaker would be great. We will begin exactly at 3:20. So with our next presentation. So look forward to seeing you then. Thanks so much. All right, welcome back. Our second presentation is from Surviving to Thriving, Understanding the Behavioral Health Needs of LGBTQ plus Coloradans, presented by T. Schweimler and Stephen Haden. T and Stephen, take it away.
Awesome, thanks so much. Let me get my screen shared here. All right, can you all see that okay? Great. So welcome everyone. Thanks so much for being here. As mentioned, my name is T. Schweimler. I am a researcher at the OMNI Institute. We're based in Denver, but work throughout the US. I use they, them pronouns, and I was the lead researcher on this project, which is the Envision U State of the State project. And Stephen, I'll let you introduce yourself.
Yeah, good afternoon, everyone. So Stephen Haden, my pronouns are he and him. I'm the Chief Executive Officer of Envision U, which is a nonprofit based in Denver, focused on improving LGBTQ mental health across the state of Colorado. We're grateful for our partnership with OMNI Institute, and funding for this project came from the Denver Foundation.
Thanks, Stephen. So to get us started, we'll talk a little bit about the methods of our project. And I'll note that this is going to be a very high-level overview of our work with this project. But in terms of methods, the goal of the Envision U State of the State project was to create a statewide assessment specific to LGBTQ plus individuals that would allow us to better understand their specific gaps, needs, and opportunities in regards to behavioral health and wellness. The primary tool of the project was quantitative in nature. It was an online survey, and those data were supplemented and enriched by qualitative data collected through interviews, both individual and small group. So we understand that LGBTQ plus communities experience a wide range of health disparities, such as higher rates of substance use, mental health issues, high rates of suicide. However, a lot of that understanding really comes from data that draws comparisons between cisgender and heterosexual communities and queer and trans folk. And when we really dive deeper into those data, we find that too often it homogenizes a pretty vast and diverse community. We find that LGBTQ plus really just means the L and G a lot of times, with little to no representation of identities beyond lesbian and gay. So we wanted to address that need to dive deeper into our community and really understand the nuances of various identities, including the intersections thereof in relation to behavioral health needs and outcomes. Now, we didn't want to reinvent the wheel. We wanted to contribute to a body of research and build upon other surveys. That being said, we were really intentional in exploring currently available data so that our efforts didn't feel duplicative, but rather continued and built upon an already existing story. We also wanted to make sure that we built a tool that's specific to LGBTQ plus individuals. We wanted to hone in on, again, those intra-community differences rather than just the inter-community differences. And with that, really, tried to build with the respondent in mind. Another aspect that was really important is that we were really intentional throughout this process to make the survey feel as non-clinical as possible. We wanted to learn more about survey respondents' experiences and needs, but we didn't want to diagnose them, and we find that too often that line really gets blurred for folks. We wanted to treat them as people, not as clients or patients. And this is especially important when working with populations who are more frequently the focus of research. So our goals with the project, first and foremost, we wanted to establish baselines that can be used to set benchmarks for progress towards our goal of equitable outcomes for LGBTQ plus Coloradans living with mental health and or substance use disorders. And we also wanted to apply and share that data broadly. We wanted to share it with organizations, state agencies, and anyone else interested to help inform strategies and priority objectives for programming, for funding, education, training, and policies. So on that note, thanks so much for being here and being part of this conversation. So in terms of our methods and our approach, we dedicated a lot of time and effort to mapping out how to reach folks. When we kicked off the planning of this effort, actually back in January of 2020, the pandemic was not yet on our radar. So we definitely had to pivot some, mainly moving away from our reliance on in-person data collection and bolstering our plan for online dissemination. And with that, bolstering our setup to prevent scammers and bots, which are too frequently an issue in this work. So for our outreach process, it was really advisory committee driven. We wanted to make sure that we went through trusted community members whenever possible, and established an advisory committee of trusted community members across a variety of identities and geographies who we supported with a small stipend. The advisory committee both helped finalize and pilot the survey, as well as drove our outreach efforts. We did some pretty extensive outreach partner mapping, really going through and identifying queer serving and queer specific networks and organizations across the state, and creating a partner tracking sheet to organize that information and any outreach activities that were conducted. I think we mapped out somewhere close to 200 organizations and businesses across the state, with everything from bars to LGBTQ+ sports teams to our large powerhouses like One Colorado and the Center. We also identified any contacts that either we or our advisory committee members had within those spaces to facilitate that communication. We identified key events where we could conduct in-person outreach. So as restrictions began to loosen in early summer, and the actual survey was conducted last summer, so summer of 2021. So as restrictions began to loosen, we kept track of any community events and identified opportunities for in-person outreach. So Envision U tabled at the center's Pride Hub in Denver, at Broomfield Pride, Aurora Pride, outreached at Black Pride events and the LGBTQ Wedding Expo, as well as various other events in the community. We also hosted a survey day at the center, coordinating with staff there to be able to reach members of their older adult coffee group and their youth summer programming. So we knew that having the survey online would be a barrier for some communities, so being able to go to people such as this older adult coffee hour was really important to us. Zach, one of Envision U's staff, was actually sat down with a lovely 90-some-year-old gentleman who wasn't comfortable using a tablet, and walked through and helped him fill out the entire survey. So we're really into that person-to-person connection. We made sure to offer incentives for completing the survey. So a $15 gift card from either Target Consumers or Safeway was offered for completing the survey, and a $25 gift card for participating in an interview. We identified vendors that had respectable scores on the HRC Equality Index and had fair business practices that we could identify at the time. We also provided an option for survey participants to decline their gift card and donate it back to the effort, to allow more folks to participate, which actually around 20% of our respondents selected that option. And I'll apologize, my dog is dreaming in the background, which is the weird yipping sound that you're hearing. Moving on, we created a social media toolkit. We wanted to make that ask of sharing the survey feel as easy as possible. We didn't want to burden folks. So everything was in a Google Drive folder, which could easily be shared and updated. So we provided that information to our advisory committee, and they also used those tools to reach out to the outreach partners and provided them that toolkit as well. So that was like pre-made social media posts, images, etc., email drafts, anything that they might need to share our survey with folks. Our largest challenge came around scam prevention across the organization and among our fellow evaluators. We've really seen a large uptick in the number of bots and scammers responding to surveys, particularly those offering an incentive. And we've seen that somewhere in the tens, sometimes in the hundreds to thousands. So going into the project, we tried to be really proactive. We approached scam prevention by utilizing a texting platform. So I'm sure we've all seen sort of those like text happy to 8675309 and get your ice cream coupon type setup. We set that up so folks could text together, which was our text word, to a designated phone number where they could receive the survey link. It had two benefits. One, they could only subscribe and receive the link once. We could change out our collector if there were any issues, and we wouldn't have to update any sort of promotional materials for the effort. We did create a landing page for the survey on Envision U's website as well, and had a dedicated email account that folks could email if they didn't have access to a phone, where we were able to provide them a direct link to the survey via email. Ultimately, we received 225 scam emails and 2 real emails from folks. Identified those through looking at patterns in email addresses and responses. They were really easy to identify. All those emails that came through that were scam were really goofy in nature. So we, overall, I think really felt comfortable. It was a huge win for us. We felt confident in the validity of the data that we gathered. So all in all, we collected 588 survey responses and conducted 17 interviews with community members. Those interviews were conducted with groups that were either less represented in survey numbers or generally less represented in research. So that was with older adults, people of color, youth and young adults under 25, and trans and gender diverse folks. So that's it on our methods part of it. There's a whole lot more, but let's talk a little bit about some findings, and I'll pass it off to Stephen here.
Thanks, T. So moving into some key findings, and I'll stress, this is really just the very tip of the iceberg. We had the difficulty and also great experience of having a lot of findings. We'll provide a link to the complete survey results as well as an executive summary document and key findings at the end of our presentation. So there were so many stories to tell, and it's always a bit of a challenge picking just a few things to focus in on such a short time, but we'll give it a try. All right, so I'll start off talking about a little bit about adverse childhood experiences, commonly known as ACEs. For those unfamiliar, ACEs describes potentially traumatic events that occur during childhood that can have a profound impact on health outcomes later in life. These can be direct or vicarious events. More events like these occur in a young person's life, a higher risk of negative outcomes. In fact, experiencing 4 or more ACEs has been associated with significantly increased risk for 7 out of 10 leading adult causes of death, including heart disease, stroke, cancer, COPD, diabetes, Alzheimer's, and suicide. ACEs have also been associated with an increased lifetime of illicit drug use and dependency, higher rates of substance use disorders, and mental health issues for older adults, and early initiation of alcohol use. So in our survey, we found that the prevalence of childhood trauma was particularly high among all groups, but in particular among our trans and gender diverse respondents. 92% of trans and non-binary respondents and 80% of those who are not trans or gender diverse experienced at least one childhood traumatic experience. A staggering 42% of trans and gender diverse individuals reported experiencing 4 or more ACEs, and 23% of those were not identified as trans or gender diverse reported the same. Again, 4 or more ACEs is really a tipping point for significant impacts on both quality of life and longevity. So now turning our attention to substance use. Alcohol, marijuana, and tobacco were the most commonly used substances, both in terms of lifetime use and use in the past 30 days. Here we see the lifetime use rates in blue, with the proportion of folks who indicated having used the substance in the past 30 days showing in gray. We saw considerable evidence about hallucinogen and psychoactive drug use, with nearly 2 in 5 folks having used these substances at some point, as well as nearly 1 in 4 folks having indicated misuse of prescription stimulants and cocaine at some point in their life. When asked about their prescription drug use, marked by an asterisk in this visual, this was specified as use without a prescription or in a way that was not prescribed. In terms of overall experiences with mental health, we dug into experiences of symptoms as well as rates of diagnoses and engagement in care. Most frequent were folks reported having experienced symptoms of anxiety disorders, mood disorders, eating disorders, which is one of the leading causes of premature death in the LGBTQ community, substance use disorders, and personality disorders. Now notice this is self-reporting of symptoms rather than any sort of clinical assessment. In addition, approximately 2 in 5 respondents reported living with a chronic illness.
All right. So continuing on that, when we look at gender here, the experiences of trans and gender diverse folks as compared to those who are not trans or gender diverse. And we ran all analyses on these along these lines, as well as several others. With trans and gender diverse folks, that's where we saw the most statistical significance and difference of experience. So here we found that trans and non-binary, trans and gender diverse folks across the board were more likely to report symptoms of all of these disorders. An interesting trend that we saw, however, was that for folks who reported having experienced symptoms, trans and gender diverse folks were more likely to have seen a provider regarding these symptoms, indicating a higher level of engagement of care. The exception to this trend was in regards to eating disorders, where trans and gender diverse folks were engaging in care at similar rates to their peers. And engagement in care here was indicated by folks saying that they had either been diagnosed and or received treatment for these symptoms. Can't click here, let's see.
All right, so we found folks were concerned about their mental health and felt they were not being seen, and that primary care providers, which is of course an important bridge to care for many, were also failing to engage them in conversations about their mental health. So you can see there a pretty significant representation of folks who were not being asked about their mental health. So next, in terms of experiences in care seeking, that worry and that fact that folks aren't being actively engaged in conversations about their mental health or substance use wasn't particularly important when we look at unmet need. When we asked folks about a time in the past 12 months when they weren't feeling well, either mentally or physically, we found that 43% of respondents either asked for help and didn't receive it, or didn't ask for help at all, even though they needed it. Folks are slipping through the crack. We are failing to engage them in important conversations. And even when individuals are reaching out, we aren't meeting their needs. When asked about why either didn't ask for help or didn't receive the help they needed, the key barriers identified were readiness to seek care, accessibility of services, a lack of LGBTQ affirming service providers, and difficulties navigating the provider landscape.
Thanks so much, Stephen. So building on that conversation around access to care, we also explored what types of spaces or services folks had difficulty accessing and what the barriers they were experiencing were. So we found that the top spaces that folks had difficulty accessing were mental health services, support groups or resources, medical or primary health care, public bathrooms, and sexual or reproductive health services. The key barriers for accessing these services included cost, convenience, and having faced discrimination or non-affirming language practices or interactions within the space. So here we can see the percent of folks who had difficulty accessing this space, with mental health services being the most difficult to access space for most folks, or reported as being difficult to access by the most folks. And then here we have the primary barriers experienced for folks. So again, cost, convenience, and experiences of discrimination.
So next we ask our respondents where providers are falling short. When folks are able to overcome these initial barriers to access, the care that LGBTQ folks, individuals are receiving is not always affirming. We asked our respondents about their most recent behavioral health care provider, both in regards to inpatient and outpatient experiences. So we found at least one in three participants indicated that their most recent provider didn't have signs, posters, or other visual cues showing that the office setting was LGBTQ friendly, didn't use a program or module specifically designed for use with LGBTQ populations, and didn't ask or address them by their chosen name, and or didn't have office policies that are trans inclusive. Further, 1 in 4 participants said their most recent provider didn't ask them about their sexual orientation, gender identity, and or relationship status. They didn't ask them about their correct pronouns. and didn't have specific knowledge or training to deliver care to LGBTQ individuals, and/or didn't make them feel comfortable sharing their experience and needs as an LGBTQ person.
Yeah, so, and meanwhile, folks who are engaging in behavioral health care services, about 20% of our respondents reported that a behavioral health provider had invalidated their identity. More than 10% said a provider had tried to change their identity. And this number was even higher with 1 in 5 among our LGBTQ plus respondents of color. So even when folks are engaging in care, again, it's not always an affirming experience. And this is really problematic as we think about things like conversion therapy and just the need to be affirmed and be respected in who you are. Shifting gears a bit, this point right here is one of those areas where we really sought to build on existing research. So we looked at One Colorado's Turning Point of Health report from a few years back, where they identified what things folks were looking for from a provider. And what we did was we asked our respondents to rank these from what is most important to them when choosing a provider to what is least important to them. The weighted averages are shown here with those ranked highly by respondents at the top and those ranked highly by the least number of folks at the bottom. So we find things like having LGBTQ plus inclusive forms, accepting insurance, being knowledgeable about LGBTQ plus health topics up there. And interesting trend here, we saw that among our trans and gender diverse respondents, things that could be construed as performative, so things like having signs, were ranked less highly as compared to their non-trans, non-gender diverse counterparts, and things that were more practice related. So things like using gender neutral language, specialization in health topics were ranked more highly among the trans and gender diverse respondents. And what folks are really looking for is pretty straightforward. So when we talk to folks, they're really seeking authenticity, care, and attention from their provider. They're seeking acceptance for who they are. They want providers to be trained and knowledgeable in how to provide them with the best care. They want to be able to afford those services, and they want to have those services actually be accessible to them. In fact, 99% of our individuals, of our respondents who participated in the survey, said that they would use a directory of affirming providers and resources to find a provider if such a resource were available to them. Folks want to be connected to resources that really enable to take care of their whole selves, so wraparound services. They want folks to respect and use their pronouns correctly. And they want to connect with providers who understand how to deliver trauma-informed care. Really vital, right? When we think back on the high prevalences of ACEs in our community and experience of trauma, folks want to have a provider who understands what that trauma can mean. And that is it on our findings presentation. Again, this is very tip of the iceberg, so I really encourage you to check out our report. And Stephen, do you mind throwing a link in the chat to the report?
Of course.
Perfect. And then want to provide just some resources. If you or someone is experiencing an emotional or mental health crisis, Colorado Crisis Service is a great resource, either by calling or texting. And if you have any questions, again, my name is Schweimler. I'm with OMNI, and then we have Stephen, who is at the helm of Envision U.
Great, thank you both so much. Please feel free to put your questions in the chat or come off mute. T, I'm glad to see your dog has arisen from its slumber, probably to go right back down, but it's very cute. Does anyone have any questions? I'll start again. So I haven't really thought much about scam and bots. That was something that I've heard for the first time today. So one, did you have previous experience where they were a huge issue, and how did you kind of handle that? And then 2, was there an individual sifting through those 225 emails? Like was there a team? Can you just talk a little bit about that?
Yeah, as far as it being issue, 100%, it's been a really significant issue that we've encountered. We recently had a couple, we had one survey effort that we had conducted that was in Colorado, that I think out of 2,500 responses, like 900 were legitimate responses and the rest were scam responses. We had another one that was a larger survey, it was several thousand collected, and I would say probably got several thousand scam responses in that too. Yeah, definitely an issue. We did have a couple of us sifting through those 225 emails. There were 2 of us, one person primarily sifting through those. Again, they were generally really easy to identify. What we found is weird language. So people being like, I volunteer for this study, or like listing out their qualifications in a very awkward way, or weird formatting where it was clearly like copy and pasted from like a mail merge or something. And as well as patterns in email addresses. So a lot with numbers, random letters, or it'd be like the name and then a random number afterwards. So that was relatively easy. The text platform was really cost effective. We used something called Slick Text. And it depends on the number of responses that you're expecting, but it was somewhere around, I would say $100 to $150 a month for a couple thousand responses. So really cost efficient, especially when you think about the amount of time it takes to dig through scam responses and find them all. Yeah, would recommend. We're using it on several other projects now after this experience. This was our first time using that platform.
Great, thank you. Can you talk a little bit more about specifically what specifically difficulty accessing care meant to the respondents in your sample, or how specifically they experienced that potentially from any of the qualitative data you have?
Yeah, in terms of difficulty accessing care, it really meant a lot of things to different folks. So the big thing was finding a provider who was LGBTQ affirming. That in itself, there's not a whole lot of them. And when they were available, we found respondents really struggled with significant wait times, anywhere from 6 months to a year wait times for an LGBTQ plus affirming therapist or mental health care provider, which of course is not helpful, especially if you are experiencing any sort of crisis and need immediate care. Cost was the other thing. A lot of folks finding providers not accepting insurance and only providing services for cash direct payments. Some did find some on sliding scales, but still had difficulty accessing services as well. So those were some kind of main themes around difficulty to access, just like the care landscape, just how complex it is of like figuring out, right? Like, who can I go to? Who accepts my insurance? Are they accepting new patients? Emotional labor was a theme that really came up a lot, of folks really having, and physical labor, of really having to do a lot of work to just be able to like get a point of contact.
I just wanted to add one other thing, which I thought was really important in terms of accessing care. Hours available to see a therapist. So traditionally we have this notion of 8 to 5, Monday through Friday. And the reality is, for many of our respondents and most folks in the community, that those times, those barriers can be really limiting for folks. So we definitely have heard from the community the need for evening hours, weekend hours. That would be a significant benefit. Transportation, of course, is an issue. And then just the number of trans and non-binary folks that are underinsured or uninsured prevents folks from accessing care.
Yeah, and the last piece I'll add is that folks really said services are really hubbed in Denver and Denver Metro specifically. So for anyone either living on the outskirts or suburbs or in other parts of the state, particularly struggling with access to care. And I see a comment here, when we looked at alcohol, tobacco, and drug use, what was our baseline alcohol at all in the past 30 days or a certain amount of alcohol, tobacco, or drug use in the past 30 days? So we asked this multiple ways. So first off, what we talked about here was just lifetime and 30-day use. And then we actually followed that up with a question for folks who had used in the last 30 days, how frequently they used. So if you look in the report, you'll see an additional visual that breaks down whether folks used it, was the breakdown, it was daily or almost daily. Oh, I can't remember what all the baselines were, but they were based on the, I believe on the GIPRA categories of frequency of use. So we asked it in a multitude of ways.
I would just add one bit of a piece of information related to that. So 25% of individuals who indicated that they had used a substance in the past 30 days had said that that use had been problematic and had an impact on their life in some way. So the significant prevalence of substance use and misuse in the community, and it's certainly impacting the community in a number of ways. And we've certainly highlighted a number of the reasons why that's the case.
Thank you. Another question is, what recommendations do you have for identifying or preventing scam responses, particularly for multiple choice surveys?
Great question. So a couple different things. I would say, if you can use something like a text platform to limit access to the direct link of the survey, that's always great. Anytime you put a direct link to a survey out into the world, who knows where it can go. So creating some kind of barriers to access, but still creating, right, like our website with the email address, ways that folks who can't navigate that can still access, right? We don't want to limit folks from participating as much as we can. So a lot of it really comes into the outreach point of controlled outreach. So again, we went through trusted community members. We were relatively aware of what channels things were going out through. We did some ad hoc monitoring. If we had like a larger batch of responses come in, we tried to figure out where they were coming from. The key thing for identifying or preventing scam responses is, or at least was for us, in our gift card collector, which is a separate survey that folks got linked to. And that was the key one, because we would find, you know, it was weird addresses that aren't real addresses, or again, like weird email addresses, things like that. So that's like a really good way. And if we did encounter something that, which we didn't with this survey, but in other surveys that we've done at OMNI, we would just link IP addresses to the responses and disqualify folks there. So those were kind of the big pieces, I would say, for scam responses. And it's hard, I think, like historically it's been a lot of like bots, and so it's like automated systems where there were easier patterns, like really short response times where it's a computer going through it, and we're finding it's really shifting to scammers. So it's actual people going through this and, you know, using VPNs and proxies to, you know, create multiple IP addresses and things like that. So it's a little bit harder to trick and identify and figure out. So yeah, those were kind of the big scam prevention things that have worked for us, but it's something that we have to very actively be aware of and plan around for any and everything that we're doing. And again, that slick text thing was key because we could close the collector. We used SurveyMonkey for this. We could close the collector and create a new one and link a new one to slick text at a moment's notice. So if there was a scam, like we just had this on another survey 2 weeks ago, we had a weird scam thing going on. We swapped that collector out, we closed it, and we haven't had a scam issue since. And we didn't have to update any promotional materials or any messages that were out there, which was really nice.
Great, thank you. Just want to make sure. And thank you all for joining us today. And thank you, T and Stephen and Christine. And sorry, I'm not seeing Whitney. Is that correct? Yes, Whitney, thank you. Thanks. That concludes our session for today. Thank you for attending and engaging in Q&A. I really appreciate it. A few short announcements before you head out. Slides and any additional handouts the speakers have provided are available on Sketch. You will receive a conference evaluation form via email after the conference is over. Please fill that out. Even if you only attend a portion of the conference, it's very helpful for our planning committee. We definitely do use your responses as we plan for next year. There will be a raffle for everyone who completes the survey within 2 weeks, and you could win one of two $50 Amazon gift cards. That wraps up today's sessions. We hope you enjoyed the first day of the conference. I know that I definitely did and learned a lot, especially in our session today. We will pick back up tomorrow morning from 9 a.m. to 12 p.m. Mountain Time. The plenary sessions begin at 9 a.m. and feature a talk entitled Community Health and the Pandemic Response in Colorado. We hope to see you there and for the breakout sessions that will follow. And to see the full schedule, the full schedule is listed on the Sketch conference website. So thank you all for a wonderful first day of the Culture of Data conference, and I hope you all have a great rest of the day and look forward to seeing everyone tomorrow.